the Tahoe Forest Hospital Board of Directors meeting. I want to welcome all of you to our June 2022 meeting. Can I have our legal counsel read us out of closed session?
Yes, thank you, Madam Chair. The board considered 5 items in closed session. The first was a quality assurance report related to home health, hospice, palliative care, and that report was received by the board. The next was also a quality assurance report related to the Beta Heart score summary. There was no reportable action. With respect to the third item, conference with legal counsel regarding anticipated litigation, there was no reportable action. The board approved the closed session minutes from the regular May meeting and the special meeting of June 16th on a vote of 5-0. And finally, the board considered the medical staff credentialing, and those recommended credentialing decisions were approved also on a 5-0 vote. And that concludes my report.
Thank you so much for that. Item 9, deletions or corrections to the posted agenda. Okay, if there are no deletions or corrections, we'll move on to 10. 10 is input from our audience. And before we start the input, I just want to let you know that this is an opportunity for members of the public to address the board on any item that's not on the agenda. And if you wish to speak to the board, if you could either raise your hand or on the Zoom, there is an icon that you could hit and a hand will wave, and we'll know that you want to speak. When you speak, if you could please give us your name for the record. You have 3 minutes to present your topic to the board. And just to let you know that we cannot really discuss it. We can acknowledge that you gave it. And because of the Brown Act, we cannot discuss anything that's not agendized. And then lastly, if you go beyond the 3 minutes, I might have to pull you off. So my apologies ahead of time, but again, 3 minutes. So on that comment, do we have any input from our audience? Remember, you can either raise your hand or you can hit the icon. Now, Janet, were you waving or just waving? All right. Seeing no hands, hearing no voices, we'll move on to input from our Employees Association. And they are also covered by the same rules, 3 minutes. And do I have anybody from the Employees Association? All right, now that they have a contract, we're not going to see them. Item 12 is an acknowledgement of our Beta Heart validation. Janet Van Gelder, Director of Quality and Regulations, is going to give us the information.
Thank you, Chairman Wong. I'm really excited to share that for the 3rd year in a row, Tahoe Forest Hospital and Incline Village Community Hospital achieved the 5 domain validation through our Beta Liability Company or organization. And I wanted to briefly share what that is. Beta Heart is a communication and resolution program. It promotes a response to harm events in healthcare that's characterized by transparent and prompt communication, support for those involved, the patients, the family, and the clinical team, and rapid investigation and closure of gaps that contributed to that adverse event, proactive resolution, and collaboration across all involved. The goals, Beta Heart is a comprehensive and it's a coordinated effort, and HEART stands for healing, empathy, accountability, resolution, and trust. And the goals of the HEART program are to ensure that our patients and families that are harmed by healthcare have their needs met, and to promote learning within and across the healthcare system to prevent reoccurrence of those events. Where, again, this is the third year we have achieved it. We're the only hospital in the beta group that participate. So over 50 hospitals, and we have achieved it for both of our facilities in 2020, 2021, and 2022. And what that means is it's a premium savings for our organization. That aside, it's a wonderful program that really benefits our patients, our communities, and our providers. Thank you.
Thank you so much, Janet. Does anybody have any comments about the data survey and the scoring? Okay. Again, Janet, thank you and your whole team for that and for keeping our patients safe,
Yes.
which is the most important.
Thank you.
Item 13, the Medical Staff Executive Committee, their meeting consent agenda, and we have Dr. Lane, who's going to present the annual policy approval.
So as I'm sure you probably know, we are required to have an annual review of all of our policies. And so these 7 were reviewed and without changes accepted, just to continue on with. We had no changes, no concerns. It didn't change from previous.
Okay. So these are the ones from Incline Village Community Hospital. And could I have a motion to approve the Medical Executive Committee meeting consent agenda that had the annual policy approvals?
Ellis, I'll move approval of the MEC consent agenda.
A second, please.
I'll second. Michael?
Okay, it's been moved by Director Brown, seconded by Director McGarry to approve the Medical Executive Committee meeting consent agenda. A roll call
Sorry,
vote.
Chair Wong, did we get
sorry.
any public comment on that item?
Oh, I'm sorry. Is there any public comment or any comments from our board on the consent agenda? Okay. If there's no comment, we already have a motion on the table. Can I go ahead and do it, David? Okay, so we had a motion to approve it, and could I have a roll call vote?
Director Barnett,
You're on mute.
Yes.
Director Shamblin,
Yes.
Director McGarry,
Yes.
Director Brown,
Yes.
and Director Wong.
Yes. So Dr. Lane, your meeting consent agenda has been approved. So thank you.
All right. Thank you very much.
So moving on to item 14, and this is the consent calendar. And these are usually reports and non-controversial documents. And the board can consider them as a whole, or they can pull something that they want to further investigate. So is there anybody on the board that would like to pull any item on the consent calendar? Is there anybody in our audience that wants to comment on the consent calendar? Okay, hearing none, this is going to be easy. Can I have a vote? So can I have a motion to accept the consent calendar as presented?
So moved. Dale.
A second, please.
Second, this is Director Barnett.
It's been moved by Director Shamblin and seconded by Director Barnett to accept the consent calendar as presented. A roll call vote.
Director Barnett,
Yes.
Director Shamblin,
Yes.
Director McGarry,
Yes.
Director Brown,
Yes.
Director Wong.
Yes. So the consent calendar has been approved as presented. We're going to move on to item 15, items for board discussion. And the first one we have is on this Tahoe Truckee Senior Service Gap Analysis. And Karen Abrams is going to present this. Karen is the Senior Vice President of Technology for Caravan Health. And she has been pursuing her master's in public health at UNR. And most recently, she had an internship here at Tahoe Forest, where she worked with the care coordinator department to do a gap analysis on the Truckee-Tahoe Community Senior Services. And if Karen looks familiar, it's because she used to be an employee here. So welcome, Karen, and we're looking forward to hearing about your report.
Great. Thank you so much for having me. Let me share my screen. We'll go ahead and get started. All right. Can you hear me okay?
Yes.
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 Great. Okay, great. Yeah, so as Alice just said, I'm pursuing my master's in public health with UNR while I'm working at Caravan Health as a VP of Information Services. And part of my program was to complete an internship, and I immediately knew that I wanted to do something local here in Truckee. I'm a longtime local resident, and I used to work at Tahoe Forest in the IT department. So excited to be here tonight. So for this project, I approached Karen Groh in the care coordination department because of her vast background in population health. And she said she had the perfect project for me to work on that Judy Newland had approached her about, which was to do some research of our senior services here in the Truckee area. And this gap analysis and opportunity analysis is by no means intended for Tahoe Forest to solve all of the gaps, but really just identify the gaps and see where potentially Tahoe Forest could help plug in some of these opportunities that we have in our community. So the mission for this project really aligns well, I think, with the Tahoe Forest Strategic Plan for Growth, which is to foster and grow community and regional relationships to meet the needs of this community. And this project obviously is focusing on the well-being of the older adults in this community. The goal of this really is to ultimately to recognize the opportunities for resources to improve the health and outcomes of our seniors. As we know, social determinants can act as barriers to one's mental and physical health. The real pie in the sky dream here would be to have a public and private partnership for a senior center in this community. So that's ultimately, the ultimate goal here if we could potentially get there. So before I dig into the work that I did on this project, I wanted to take a moment to talk to you a little bit about the care coordinators that I worked with on this project. If you're not familiar with that department, what they do is they really facilitate discussions across all the different stakeholders to advocate for the most complex patients that we have in this community, their wishes for their dignity, their comfort, their basic needs, and really their overall health. The care coordinators are often told that they're loved. Their patients say, "I love you," and it's not in an inappropriate way. It's really because it's the only way that these patients can convey their gratitude for the help that they receive through CCM. Knowing that they have a confidant and an advocate on their healthcare team really helps relieve their stress and really improves their overall health outcomes. Now, a concerning item I wanted to share with everybody today, I've learned so many stories about the patients that they're working with in our community, and I wanted to share one specifically. This is about a longtime Tahoe City resident. He's in his 70s, he's dual eligible, he has several chronic conditions, and he hasn't had a driver's license since the 70s. And he requested care coordination assistance to help him with the paperwork and go through all the logistics to get his driver's license so he could purchase a truck. And the care coordinators found out the reason that he wanted to purchase this truck was so he could have backup housing plan because his apartment that he was renting is on the market. And of course that got sold. And this gentleman, a longtime, resident here, is now living in his truck in the forest. And that's just one of many stories that the care coordinators have shared with me about what they're trying to do to help the residents in our community. So as a nation, we are living longer. By 2016, or between 2016 and 2060, the population of age 65 years and older in the United States is expected to double. And 80% will have more than one chronic condition, 77 more than two, 75% will require long-term care, and about 40% will require skilled nursing facilities. And we really need to prepare for this. So just some local demographics that I found on through the U.S. Census Bureau is that, as of the 2020 census, we're just under 17,000 residents here. I think we all know that that might be a little light considering census took place in 2019, before the boom, before the pandemic. 15% are 65 years and older. 13% are on Medicare, 10% on Medicaid. 10% of our population have food insecurities. About 18% are considered obese of our adults. And this was the most staggering one to me, was about 25%. This is Nevada County, not just Truckee, but Nevada County residents. We have the highest excess drinking rate in all of California, Nevada County. So about 25% considered an excess drinking. Yeah, that was staggering. Couple assumptions I wanted to address before we dig into the methods that I use for this project is, the things that I've heard around town and the care coordinators have shared with me is that, Truckee already has a senior center. Like, why are you doing this? And we don't. We have the senior apartments has a community room, but certainly not a full service senior center. In fact, it's zero service senior center besides the senior apartments. Another assumption is that community members, they leave Truckee when they get older in Truckee Tahoe area, and that's not true either. I did a survey, and I'll get into all the details on that in a few slides here, but about 80% of our residents are planning on aging here in this community. The aging population is a healthy population, and yes, maybe compared to other counties in California, but as you saw on the prior slide, 25% of us have an excess drinking problem, which we know leads to adverse health outcomes. So that's an assumption. Aging population is mostly affluent. The work that I've done throughout my master's program is that's certainly not true. We have about 30% of our children are on free and reduced lunch. You saw that 10% are on Medicaid. So we're not all affluent here in this community. And lastly, during the pandemic, the population grew here, but it's really just the younger population. And again, that's not true because whole families moved up here to Truckee. People brought their parents and grandparents along with them when they moved to Truckee, and we're continuing to grow at all ages. Right, so the methods that I did in doing this project was a community survey, and I'm going to get into those details in a few slides here. I did a MyChart electronic survey and a paper survey. Did a paper survey to the residents of the senior apartments. I did 7 key informant interviews to various experts around the community, the care coordinators, of course, Meals on Wheels, Sierra Senior Services, the director of the senior apartments, couple churches, various community members, a physician, Dr. Standheiner, and also Sierra Community House. Did research on our local senior service inventory. Karen and I did a site visit at Washoe County Senior Center, which was pretty cool. And then lastly, some education on the age-friendly ecosystem and age-friendly health system. And the findings really is that overall finding is that it's a pretty confusing landscape here in our community. And we have siloed and uncoordinated services, senior services. We have, people doing a lot of work like Sierra Senior Services. They really do only do Meals on Wheels, and they're pretty maxed out. They don't even have a large enough kitchen to serve all the needs in our community. Sierra Community House, they do amazing work. But they're not focused on seniors. So they're not excluded, but they're really focused on families, hunger relief, crisis intervention and prevention, and family support. The Parks and Rec, they just started adding senior activities to their calendar, which is so exciting to see. I think there's one a week at this point in time. Placer County and Nevada County, of course, have services, but we tend to be forgotten about over the hill here. People don't want to drive to Truckee in the snow, and we just don't have that local county resources here in our communities. Then, of course, Tahoe Forest doing the community health and wellness programs. All right, so the survey that I did was through my chart, and there are 16 questions. In the appendix of this presentation, I have all the questions and all the responses to each question. I'm not going to go through all of them today. I think there's like close to 100 slides in this deck here, so I won't put you through that, but I wanted to highlight a couple in this presentation. But there were 16 questions. I got 650 responses, which I was really pleased with. But I did think there was a little bit of bias based on the fact that it was sent through an electronic format through my chart. You obviously had to have a device and internet access, and of course the ability to log into my chart. So based on the bias, we did a paper survey as well. To the senior services or senior apartments. I delivered 60 hand addressed envelopes and paper surveys. Got my kids helping me. We hand delivered those in March, and at the time that I compiled all the data, I had 23 responses, which I was also pretty pleased about. I continue to get responses. I think I got one yesterday actually in the mail, so there's probably closer to 28. I just need to take the time to compile the rest of the data. Right. So the overall survey response themes were regarding transportation, housing. I mean, none of these are really a surprise. Socialization opportunities. I mean, that could be post-pandemic talking. In-person fitness opportunities for our seniors. Some of the comments that I've received is that, so the seniors are sometimes, afraid to go walking on our trails because of all the dogs, and it's just not conducive to fitness for our seniors in our community. Age and place services. As we all probably know on the line, it's hard to find a good contractor, a handyman for anybody, let alone trying to find somebody that can retrofit your house to make it a safer place for you to age at home. The cost of living, of course, problem for everybody. And I thought I'd throw this in there, not directly related to senior services, but lack of timely appointments. It seems like it was such a popular comment in the survey that I wanted to just highlighted it, that folks are saying that it's taking a really long time to get in to see their primary care doc. But again, I think that's happening across the country as well. Lastly, I do want to say I did receive a ton of gratitude in the comment section for conducting the survey. And I really think that just shows, that the community feels that they are being heard, which is good. One question I wanted to highlight was one of the questions in the survey was, what are the opportunities in our community to improve health in our aging population? Check all that apply. I thought this was worth highlighting. 55% wanted more exercise opportunities. 45% felt we needed more transportation, affordable housing, home maintenance, socialization, and about 20% worried about future assisted living needs. Beyond the survey, the key informant interviews, these are the folks that are the experts working with this senior population. And the feedback that I got from them was a lot of isolation. Some of the seniors are extremely isolated. there's some themes here, obviously, transportation, a lack of adult daycare for some of our seniors, again, uncoordinated system of services. They have a hard time navigating what services are available. Housing, a need for geriatric medication management. The care coordinators see a lot of that. The senior population doesn't really know how to take their medication properly. Family and caregiver support, exercise opportunities, of course, seeing that again. So here are the gaps. When we compiled all the data, here's the gaps that we see in the community. We don't have a senior center, of course, transitional housing, geriatric pharmacist, age-in-place, transportation, although we have some, it's not enough. Affordable exercise opportunities, silver sneakers. I think Tahoe Forest used to offer silver sneakers through the center, but that doesn't appear to be happening anymore. There's no other gym that does silver sneakers. Affordable housing, chiropractic and acupuncture for our seniors, and then, of course, socialization. And then here's like the opportunities that Karen and I thought that potentially Tahoe Forest could help with. And really it's that private-public partnership for a senior center. And, whatever that looks like, it could be that maybe Tahoe Forest, could have the FTE being a director of the senior center or donating the land or whatever that looks like. But having a senior center here in the Truckee Tahoe community would be an awesome service for our aging population. Another opportunity could be for some caregiver services under the home health and hospice umbrella. There's some really great waiver programs out there that could assist with offering these caregiving services. And then potentially considering becoming a certified age-friendly health system model. And I have a slide on that I'll go into, I think, the next slide, actually. So just one slide on age-friendly. It's an American Hospital Association and an Institute for Healthcare and Improvement initiative. And it really focuses on, social determinants of health. And it sparked a huge movement over the last 10 years. And it really focuses on this framework of what matters most to the patient, their medication, their mentation, managing their mental health and their mobility, which will enable the patient to do what matters most to them as they age. And that's all I have today. So thank you for letting me share this with you, and happy to take any questions.
Yeah, this is Director Barnett. Can you describe for me, if there is a senior center facility, what would take place inside that based on your understanding and background?
Sure, yeah. So a senior center, it could be, the typical senior center will have a lot of different services, but I've highlighted, the main services here. We could do transitional housing, adult daycare, there's transportation at a typical senior center, a lot of social activities, bingo, exercise, meals on wheels, volunteer opportunities. Like even at Washoe County, they have, an attorney that comes in once a week that helps the seniors with paperwork and legal services. It could be vast.
Okay, thank you.
Mm-hmm.
Karen, what I find is that there are a lot of services out there. It's what you say, they're not coordinated. I know just recently Parks and Rec started the Golden Program, which is covering a lot of what you're proposing, like socialization.
Mm-hmm.
They have exercising. I'm not sure if people know about it. And also, it's always that issue of getting there. It's at Parks and Recs, which I think is locally, and its location is good, but I'm not sure why it's not used. But definitely, it's something that's growing. They have like 50 some people there at one time for one of their Thursday morning meetings. And it really is quite the socialization.
That's
And
awesome.
people would run into people they haven't seen for 10 years. And it was so exciting to watch that all happen.
That's great. Yeah, I'm so happy to hear that. Yeah, I mean, and a lot of this is timing, right? It's post-pandemic, right? So your Parks and Rec did have senior offerings that they're just starting to ramp up again, which is great because we need to be social. We're social creatures by nature.
And maybe at some point, the rest of the board might be interested in looking at the age-friendly health system model. I know that American Hospital Association had a presentation on it, and it's pretty straightforward. And it might be something just to learn about since our population of seniors is growing. Any other comments? Any seniors want to say anything?
Aren't we all?
Well, I was building off your comment, and Karen, I don't know if you got a sense. It looks like you maybe talked to some of the other agencies, or maybe you were just pulling from publicly available data. But did you get a sense that there's an openness or a willingness to collaborate across some of the services that are out there?
Yeah, I think that there certainly is an openness. I think everyone's just really pulled for resources, right? So, Sierra Senior Services, for example, when it took me a long time to get them, to get a meeting with them. And once I did, they gave me some great input, but it's just a sense of like everybody's in panic mode almost, right? Like they're so overburdened with so many seniors that they're serving right now. And I think that any willingness for some sort of collaboration would be extremely helpful.
This community has some special challenges. Geographically, we stretch from, Sierraville down to the west shore of Tahoe to Homewood and past that, and if transportation is a problem, obviously it's going to be exacerbated by the size of our district, and couple that with the fact that we have 4 or 5 months of snow that makes it difficult for people to get out and get around. Are there any communities like ours, given those two factors, that have successfully come up with a senior center?
That's a really good question. I'm sure there has. In fact, if it comes to me, I was talking to Karen not too long ago, and she was doing just a camping trip with her husband recently, and she went through this small town, I think in this, where was it? It was like in the Southern Inyos area, I believe. I'll have to double check that, who had a senior center. She was like, I couldn't even believe it that they had a senior center. But that's a really good question, is try to do, maybe instead of doing like a best practice, research with Washoe County, try to find someone that's a little bit more similar to our community to do that with.
Yeah, well, I'm personally, I'm always one who says I hate to reinvent the wheel. Mm-hmm. And copying someone who has had success, it may be a good way to kick off a program that gets this whole thing accomplished. So something to think about.
We could reach out to the other administrators of critical access hospitals, which obviously are generally found in rural towns, and ask them if they have a partnership, or at least know of a successful senior center in their rural area. So that might give us a few names.
Mm-hmm.
Yeah.
Chair Wong, this is Ted.
Hey, Ted.
I wanted to add one thing. About 10 or 12 years ago, the Fitch brothers in Truckee proposed a senior center on the property that they own up by the Cottonwood. The sad thing was the community, the staff said at the town, great idea, wrong location. So they gave up on that concept. So there have been some attempts in the past. I think with Karen's findings that the issues are perhaps more acute today than they were 12 years ago. And maybe that has changed. Maybe that mood has changed. I would suggest, Karen, this would be a very interesting presentation to do before the town council.
Yeah.
Thank you for giving it, by the way.
Yeah. Thank you for your help.
Any comments?
Yeah, I have a question, and I'm curious as to whether or not there are any other places in Nevada or Placer counties where the county itself has stepped up. Is there anything going on in the western parts of our respective counties?
I mean, they definitely have services for seniors. They do not have an actual senior center in our county either.
And in any part of the county? East or west? Okay, thank you.
Yeah.
I know in the town of Albany, in the Bay Area, they have a senior center that's supported by the town of Albany, where seniors come and there's activities in the morning, there's lunch served in the afternoon, and they have other activities in the later in the afternoon, but I'm not sure of, if there's a pricing to it or how they get there, but it seems to be well attended on the days that I've passed by it. So again, a small town.
That's similar to my experience with jurisdictions. Often there's a nonprofit that's supported financially to some degree by a city or a county that they partner with. And then there are, I believe there's other, resources from the seniors themselves to pay for those services as well.
Well, lots to think about, lots to contemplate, lots to discuss, but thank you so much, Karen, for bringing that forth and stimulating some discussion on our seniors, because we're all going to get there.
Eventually.
Yeah, thanks, Alice.
Going to.
We're going to be there.
Hopefully.
Yeah. And some of us sooner than others.
Yeah, you're right in the sweet spot here.
Yeah.
Okay, we're going to move on to item 16, and this is for board action. We've got the Fiscal 2023 President and CEO incentive comp criteria. And I think Mary, as the chair of executive comp, you're going to present.
Yes, thank you, Alice. Yes, thank you. The executive comp committee met last week to review the metrics for the CEO's compensation for the coming fiscal year. Let me just back up a little bit. Last year, if you recall, we increased the at-risk compensation from 15% of base salary to 30% of base salary. And when we did so, we were asked to be sure to set the goals a little higher, perhaps, than what they had been in the past. And so, we contemplated that a lot. And just as a sidebar, when an organization is doing as well as ours does in so many ways, there's just not always a lot of headroom to be had, but we certainly tried to find a middle ground between establishing, a reasonable goal, but a forward-looking goal at the same time. And we were also very aware. We looked at some guiding principles before we went into this. And one of the things we talked about was that we didn't want to set goals that were so high as to be unattainable and therefore be demoralizing to those people who are really already working so hard to do so much. So we took all of that into consideration and talked through the several goals that you have presented to you in your packet, which I will go over and grab as well. But the first goal is always finance.
Yeah.
And we have always had the same goal for this particular metric. And that has always been to meet or exceed the budgeted net income. But what's really different about this metric this time is what I think Crystal alluded to several times in that this is a much more aggressive budget than we may have had in the past. So that has in and of itself set the bar higher. So that's our finance goal, and that represents 53% of the incentive compensation.
And Mary, in the past,
yes.
we've also said that if the finance goal isn't reached, then there isn't any payout. Is that still in effect or no?
We are leaving that. We talked about that, and we didn't make a decision on it intentionally because we wanted to leave it at the discretion of the executive comp committee.
Okay.
And then Mary, for finance, was that?
Yep.
Was it used to be 60%?
It used to be 60%. We took 7% away from finance and distributed it to 3 of the other categories. We left growth as it was at 10%, but we took 2 of the 7% and put it there in service, and then 2 in quality and 3 in people.
Okay, for what reason?
Because we felt that we had, well, for several reasons, one of which was the optics of it. We felt that we were about more than just the bottom line. And so we wanted to give the merit to the service and the people and the quality that we felt they deserved as well.
Okay.
Okay. So that does, any other questions about finance? Okay, well, that moves us then to service. Service is measured by the Press-Ganey patient satisfaction score. And that average goal has been to meet or exceed 93.76% for quite some time. So this will be a definitely a stretch, but one that I think that both Harry and Louis were very confident can be met. Okay. Any questions on service? Okay. Well, quality is, as we all know, yet another very high performing area. But we are going to challenge ourselves to continue to improve in this realm. And what we've done is we've moved up the quality bar from meet or exceed 97.20% to 98.20% of the various quality measures. Now, the measures change from time to time, but I don't know that they changed this year. These look to be all the same as our quality measures from last year. Okay, any questions about quality? Okay, so that takes us to growth. Again, that's a number that we didn't increase from 10% of the overall incentive comp, so that remained there. This one was very interesting in that this is really the one area where we decided to keep it at its status quo. We've all heard about the difficulties around physicians and physical space and all of that, and felt that we would be frustrating ourselves and maybe frustrating our patients if we look to take on too much in this area. Crystal had done a wonderful examination of the physicians that we had lost over the past year and how many patient visits that represented. And so, again, we just decided that what we would do is we would say, if we can do as well next year as our final number for this year, that we'll be satisfied with that. Okay. And then the last item is the people score. This is a score we alternate every other year between surveying our employees and our physicians. This coming fiscal year will be an employee year. The last time we did the employees, we set a goal of the 80th percentile in the engagement category. This year, it's up to the 90th percentile of engagement. And I don't know if you are as misguided about what is engagement as I was. I thought that engagement had to do with the number of people who took the survey. But in actuality, there is a way that Press Ganey looks at all of the scores and comes up with an engagement score. And that engagement score is intended to tell you sort of what the success of the employee is apt to be. How they feel about their job, how they feel about staying at their job, all those kinds of things will come up with this engagement category. And so what we are anticipating or hoping is that these employees will reach the 90th percentile in that particular engagement category.
So Mary, can I ask a question about that, people? Because now we're talking percentiles. I think in the past, we've always had a score. Last year it was 3.92. So why did we change to percentile? Because of the engagement concept?
Last year it was 3.92 on particular questions that were asked of the physicians. That was a physician survey.
Right.
This will be an employee survey.
And when the employee survey in, I guess it was 2019, it was also a score. It was 3.6.
Okay. I don't know, Alice. I just know that
the prior time to that, it was percentile, and we could either go down the road of specific questions or an engagement score, which really reflects a lot of important attitudes. And I think with everything that's going on across the country, we really talked about really a yeoman's effort to hit the 90th percentile on employee engagement, which probably almost no company in America could do, rather than focus on 3 specific questions, let's say.
Okay.
Gary, how would you define the engagement category, and what is engagement?
Can you repeat that, please?
Yes. How do you define engagement?
The Press Ganey survey has a standardized process that they've used for years, where let's say there's 70 questions, and they pick a variety of questions that really reflect engagement or alignment or, management or different things like that. And engagement, when you look at their dashboard, the first and foremost score that they share, which we shared during this particular meeting, is employee engagement. And then they have other scores that are kind of secondary to that, but it's always on their dashboard. Number one, based on these variety of standardized questions for hundreds of facilities, certain questions add up and create a weighted percentile score. And so the discussion was we could have some questions, or we could go to an engagement process. And the committee did agree, let's try the engagement score this time, recognizing that employers all across America in healthcare and across outside of healthcare experiencing huge challenges, but let's still set the bar really high and see what we can do on engagement.
And I might be able to add some clarity. The engagement indicator, as defined on the Press Ganey website, is a metric of items that measures employees' degree of pride in the organization, intent to stay, willingness to recommend, and overall workplace satisfaction. The score, which is usually a number, such as last year or last time we did the employee engagement survey, we got a 4.43, and that put us in the 90th percentile of comparing us to other organizations. And so this percentage is really comparing us to the national average and how we are following with our peers.
So Alice, to answer your question, there sounds as though there is a hard score that will lead to the percentile score.
Exactly. Thank you, Mary.
So that, yeah.
And then Mary, before,
yeah.
I mean, we'll vote on it, but we need to get the finance and the office visits in there as well at the end of the month, correct?
Well, the budget, it says basically the board approved budget, and so you can't act on it today because you've defined what that is, and there won't be any wiggle room in that. We'll just, we'll fill it in now that you've described it.
Right. So it'll be the, what was it, 23 million, the 22.7 million net income that we approved earlier in the budget will be the number that will go into finance.
And we'll have to wait for the number for the office visits.
Right. But what we do know is that philosophically, our goal is to meet or exceed that number. So I think we can move ahead.
Okay.
And, and I hope that you all find that this both acknowledges the wonderful work that's been done in the past, but also moves the organization to, hopefully some steps forward in the whole process.
And if I could respectfully share, to keep everybody on the same page with good, efficient forward progress, we have about 60 to 70 individuals, our managers, our directors, and our administrative council members all face the same criteria here, so that we're all singing off the same piece of music in our forward progress and our goals. And so these standards that you set or whatever you approve today, will apply to me and that audience.
So it will cascade down through the rest of the organization, which is an important point. Thank you, Harry. So with that, the committee hopes that you will agree that these are good goals, and the committee recommends that you approve these goals for the coming fiscal year.
Do we have any comments?
And I appreciate your thoughtful changes here. I think there's some really good alteration to this program, and obviously you've got a buy-in from top administrators, so that's good too.
Thanks, Dale.
Michael?
Yeah, question and a comment. The comment first, one, echoing what Dale just said. Based on comments made last year, I think the changes reflect some of the topics that the board raised. One, too much focus on finance, but then two, stretch goals. So both of those were addressed. So thank you. With regards to the goals, and I apologize if we covered this before, are they binary? Meaning if we're $1 off from net income, it's nothing? Is it all or nothing? Or how do we address if 80% of the goal wasn't met?
Those were
a sliding scale.
Right. Alice mentioned, or somebody mentioned, I guess it was Dale mentioned something earlier, and to your point as well, those two about whether or not if finance wasn't met, do we, is that all or nothing? And also, is it a pass-fail situation with the individual metrics? And we decided to leave those questions at the discretion of the committee in the event that those goals are not met.
And ultimately the full board.
Yes, always.
Yes, yeah.
Any comments from our audience in regards to the incentive comp? Okay, if not, Mary, can I have a motion?
I would make the motion to approve the fiscal year 23 CEO incentive compensation criteria as presented.
A second, please.
I'll second, Michael.
Go ahead.
Okay, so we've got Director Brown, seconded by Director Barnett, to approve the 2023 President and CEO incentive compensation criteria. Could I have a roll call vote?
Director Barnett,
Yes.
Director Shamblin,
Yes.
Director McGarry,
Yes.
Director Brown,
Yes.
Director Wong.
Yes. So the incentive comp criteria as presented has been approved. Thanks to the Executive Comp Committee. I know that it was a discussion that you had that went back and forth for a while, and we appreciate the outcome of that and look forward to a successful year for Harry Weiss.
Yes.
Thank you very much. We appreciate it.
Moving on, item 17, we did not pull anything from the calendar. Item 18, our board committee reports. Does the Executive Comp Board Committee have anything else they want to say or present?
No, thank you. There were a few policy changes, but those were approved in the consent calendar.
All right. Thank you again for your work. And then most recently, the board has developed an ad hoc committee on population health. And this came out of a retreat that we had earlier this year, and an ad hoc committee was agreed upon. We have representation on it from Director Brown and chaired by Director McGarry. So we'd like to hear what the committee has met and what the process has been so far.
Well, happy to report out on that. We had a kickoff meeting about 2 weeks ago, was joined by Mary, Ted, Louie, Harry, Martina, and a few others. So feel free to comment if I miss anything, but a really productive meeting and even not to get nuanced on words, Alice, but you call it a population health ad hoc committee. We even debated, is it population health? Is it community health? Is it, what's the objective of the committee? So it was very much a foundational or a kickoff meeting, even discussion around what is an ad hoc meeting or what is an ad hoc committee and how do we operate? A number of things were identified in the meeting, though, and I think a fantastic presentation this evening by Karen, in that there's a need that the need for the committee is a lack of visibility or a lack of data into the overall health of the community. And we've talked about this at times in prior meetings, where we feel really good about if someone comes into the health system to receive care, it's a really good chance it's going to be tremendous care. But we have a little bit of a blind spot on, let's take the seniors in the community as an example. If they're able to receive care, it's great. Are we meeting all of their needs though? And how can we as a health system better address those needs and not limit just the senior community, but other communities, other pockets within the community? And how do we get that data? And I think that was probably the one theme that really came through loud and clear is, what is that information we're missing? How do we get that data? And it is really going to, I think, be the focus of the committee for the next few meetings is what data is already available? What data are we missing? How can we go get that data that we are missing to really inform a decision around where can we have impact? Phase 2 of the committee would then be solutioning, right? Here's the data. Here's what we're seeing. Here's some gaps. Here's some opportunities. What are some possible solutions that we can pursue either as a health system or in coordination with other community services? I think that was another theme that came through in the discussion. We might be a central source. We might be a trusted source within the community, but it doesn't fall on our shoulders completely to meet the needs around the overall health of the community. So how do we work with other agencies, other groups within the community? And then the third part of the third phase would actually be picking something and acting on that. The time frame of that still to be determined, but actually having measurable impact on the health of the community. So 2 big takeaways. One, the data we need, and the idea would be that data becomes a regular part of board meetings, right? Again, to be determined on the frequency of and type of data, but getting a regular report from or about the community and how we're meeting the overall needs of the community. And then 2, actually implementing some new programs was a suggested goal, I'm going to say at this point. No decisions were made, right? Very, very informational, very much a discussion at this point. So we're going to be meeting again. We did talk about a cadence of maybe every 4 to 6 weeks, getting the group back together. Even who's in the group is still up for debate, right? Who should be part of the committee? So we'll be sorting that out over the next meeting or 2. And then we'll also adjust the cadence of the meetings as appropriate, once we get some clarity. Any comments from others that were present at the meeting?
No, I thought you described it very well, Michael. In addition to, having done a great job in setting the tone and setting the goals for the ad hoc committee. So thank you.
Any other? Louis?
Yeah, just only comments I'd add is it's a very encouraging group. I think everyone's looking at it, maybe bringing some different expertise to the group as well. We're lucky to have Maria Martin and Lizzie with us, and they continue to bring data. And I think our next go around, we're going to really look at the community health needs assessment that was recently performed, go into a deeper dive there, and look at what those other foundations or associations that we work with regularly, where are they fitting into this? We're going to actually really define which group does what, so that we can kind of figure our pathway out as we continue to look for ways that we can improve the health in the population that we seek to serve. So it's a very encouraging group, and I'm enjoying the conversation.
Great, thanks, Lee. And that's it, Alice.
Any comments from our audience? Okay, so then, Director McGarry, are you going to name your ad hoc committee, or are we going to just keep calling you ad hoc?
We're going to have a competition.
Oh, okay.
Yeah.
And are we going to be drawing posters as well?
No, we will over the next meeting or 2. We'll seek to formalize a lot of the activities around the ad hoc committee, and we will, even though my understanding the ad hoc committee operates somewhat outside of the requirements of the Brown Act, but we do intend to have obviously regular reporting back into this meeting.
And then also, the ad hoc committees are under the bylaws of the board of directors. So we have commissioned to have this ad hoc committee with a purpose, and that it'll last through the year from July to June 30th will be the last of the ad hoc committee. So hopefully all of your work will be formalized. And if we need to move on, then another committee will be then focused on whatever that solution or whatever it is. David, do you have any comments on ad hoc committees, since this is the first one that we've had?
No, you are correct. Ad hoc committees do not need to comply with the Brown Act, provided they are advisory, are composed of less than a quorum of the board, and have a limited duration, whether that's based on a time limit or a particular project. Those are exempt from complying with the Brown Act.
Okay, thank you. So we're legal, Michael.
Yeah, it's always good.
I know you were really sweating that part of it.
I don't look good in stripes. Yeah.
Okay. I think that was all the committees that have met since our last meeting. Then we'll move on to 19, board member reports and closing remarks. Anybody have some board member reports?
Alice Dale here. I should advise the board that I continue to meet monthly with the Incline Village Foundation Board. They operate very autonomously from the hospital system itself. You know, the monies they collect go to projects and programs and equipment and benefit just the Incline Village and not the whole hospital system. but they're an active group. They're very involved. They're very successful at the fundraising they do. And once a month, I, along with Harry and Louie, attend their meeting, and I just bring them up to date on anything that Harry or Louie doesn't mention about the operation of the hospital board. Yeah, I go through the previous month's agenda and pick out an item or two that I think might be of interest to them, and I bring them up to speed. It's always a very brief report, but they seem appreciative and makes them feel a little more connected to the whole hospital system, I think, to hear what we're as a board doing.
Absolutely. And I think it's true of our Tahoe Forest Foundation as well. It's making that connection with them. Not that you had anything exciting or dynamic to tell them, but just that you're interested in what they're doing and here's what we're doing. So thank you. And I thank Michael for going to the foundations and just sharing the board's activities and listening to what they have to say.
Yeah.
Okay. The one thing that if nobody else has any comment, the last comment I want to give is on enterprise risk management. And this was a term that I never knew about. I always thought about compliance as being everything. And it turns out compliance is only part of enterprise risk management. And today when we had our budget meeting, it just gave me the idea of what our appetite for risk is. Are we aggressive? Are we moderate? Are we conservative? And it really depends on what domain of that risk we are looking at. So I would hope that during one of our retreats that we could talk a little bit more about the enterprise risk management process we have at Tahoe Forest. We know parts of it, but how is it all integrated? And I would appreciate that, certainly, now that I've learned what it is.
Yeah. Are you like me, Alice? I flunk every one of those tests the first time around, and then I'm able to pass it after listening to the presentation.
I know, it's because we didn't know about it. It wasn't part of our domain. But you know, it was really interesting because remember back when I first got on the board, consumerism was the buzzword.
Yes.
And then it was disruptor, and that was another buzzword. And now we're putting all those buzzwords together and we're into enterprise risk management.
Whole new language. Yeah.
Yeah.
Just tangential to your comments, though, Alice, I just want to say that the iProtein has been very enjoyable. So I know that's a program we kicked off recently, the last few months, but I personally really enjoyed the content and find it informative. So,
yeah. Well, thank you. Thank you, Harry, for getting that, and also for Ted, who was the one that found out about it and brought it to us. So thank you guys again for enlightening us. Any other closing comments? Okay, hearing none. The meeting is adjourned.
all right. Have a great evening.
All right. Good night.